But yeah, welcome to the show. And today we're seeking to answer the question, that's the main question on the table, it has to do with, is COVID-19 still a pandemic in Ghana? And the reason why I'm asking this question is because if you look around, it's obvious that people are not at all observing the protocols, the preventive protocols. And so we find ourselves in a situation where people are going about and they don't have any mask on. And it's quite troubling. But, well, yeah, there are people who actually think that COVID-19 is gone. But yes, I'm going to put the question to you. How do you see the way we're handling COVID-19 right now? I want to start with you, Dr. Yabediakon.
Thank you, Israel. It's good to be back. Yes, it has been a little while.
Yeah.
It's difficult to say, to be perfectly honest. I think we are at the stage of the pandemic where complacency is definitely setting in, but in some ways the complacency is somewhat understandable. I think the issue we have is the reality of COVID appears to be very different depending on where you are. So the clinical manifestations, the severity of the pandemic appear to be manifesting in different ways. So if you look at Europe, we are in the middle of what appears to be a very strong second wave. Italy is going back up. The UK is rising. You have tier 3 lockdowns in Northern England. You have London up to tier 2. It appears as though we are almost going back where we were in April in terms, at least, of the restrictions that the governments are imposing and the increase in cases. The US seems to be where it has always been, which is an alarmingly high number of cases that appears to have plateaued, but not plateaued at a low point. And so it's increasingly difficult. I think the political situation in the US also does not help. Being an election year, being so close to the election, everything is incredibly polarized and the messaging is mixed. The president of the US himself has had COVID and you could argue has responded in typical Trump fashion. But then if you look in Africa, at least in Ghana especially, we appear to have seen a decline in the number of active cases. But once again, that decline is tied to testing. And I'm sure Kwame will talk about how, what he's been saying all along is that we're not testing enough. And if you look at the number of tests we're doing way below our full capacity. Having said that, I think Ghana Health Services' argument is that people are not presenting at the hospital the way they were before. We are focusing on people who are showing up with symptoms, and our treatment centers are relatively empty. So it's difficult to really put a fine point on where the pandemic is in Ghana. I don't think COVID has gone away. I think actually the serological evidence from work that we have been doing at the university bears out what has been published in Kenya and in Ethiopia, that you have high levels of antibody response, antibody prevalence to COVID.
Dr. Bediako, we're going to be coming to the details there, and would love to have whatever research work that has been done. But I'd like to come to Nana Kofi Kwache. Nana, what do you make of what's going on as far as COVID-19 is concerned?
Well, I think I generally agree with Yao on what's going on and what the perspectives around the world are. I'd say the plain fact is that COVID-19 is still a global threat. It's a major global health crisis. What we are seeing in Europe right now is quite a clear evidence that if you relax, if you get complacent, if you get, cocky about how dangerous, how quickly things can escalate, you will pay the price. And we're seeing that in France, we're seeing that in Spain, we're seeing that in Italy. I think in our situation, it's quite troubling because, for any epidemic, what you need to have a big problem is a virus that's spreading in the population and no real behavioral adaptations to that virus. So we have in Ghana a situation where people are not wearing masks, people are not social distancing, people are having large crowded events. And we have reached a point where almost insisting on the COVID protocols and wanting to follow them is actually the aberration, not the norm. And that creates a scenario where, you know, we just are not really effectively paying attention to what is a really serious crisis. And I do think that a lot of that has to do with the risk communication that's going on right now. I think I remember I saw a tweet a couple of days ago that was referencing something that Richard Ahiagba said, that people were not following the protocols and all this stuff. And I thought what we have to be asking ourselves right now is, why is there that degree of comfort with the virus? Why are people so relaxed? And we have to really interrogate that quickly, because with the airports open with antigen testing and COVID-19 on the rise around the world, we should not be naive about what those risks pose to us. And it's a bit disturbing that in that context, we're not really doing any of the things we need to be doing, from testing, from tracing, you know, and also just the behavioral adaptations that we need to do.
So shortly, we're going to have Dr. Franklin Isiru-Bequin join us. I don't know, apparently he must have a challenge, but it's obvious when I actually post on Facebook, the kind of feedback I get. Most people just say that, look, I should forget this whole COVID thing and that COVID is not real, COVID is gone. And they have also, in a bit, I would want to actually go to some of the comments that I have, but I'd want to bring in Kwame Sapon-Esiedu so that he also tells us, well, he is not in Ghana, but I'm sure he monitors a lot of what is going on here in Ghana as far as COVID-19 is concerned. So what's your take? How do you see the way we're going about business as far as COVID-19 is concerned?
Thank you, and good morning to all of you. Like Yao said, it's been a while. But Yao picked my mind in what he was saying, that I would be looking at the numbers. It's true. I mean, we are testing less than 900 samples a day. And if you put it in context with our test capacity of about 5,400, it means we are not testing anywhere near what we were doing. And yes, I understand that as the positivity went up, it became difficult for the likes of Yao and Co to test with the pooling technology they were using at the outset. But if you speak to friends who work in any of the testing centers, what they tell you is that they are not getting as many samples flooding in as happened around May, June, July. In fact, around June, it was at its peak when there were backlogs and all that. Why is this happening? It is happening because of our test strategy. And our test strategy has been, like Yao said, to test people who have appeared in hospitals and other facilities unwell and meet the sort of case definition for COVID. But there is a research paper that came out yesterday, 2 days ago actually, from the University of Oxford, because the UK was using a similar test strategy. And it says that if you do so, you miss about 70% of your cases, because about 70% of the people are mildly symptomatic. And because of the apathy, initially it wasn't the case because contact tracing was going on, but with the apathy going on globally, it's not just in Ghana, with the global apathy, a lot of the people get the mild symptoms and they can't be bothered even going to test or even isolating, to the point that in the UK now, as a result of this new finding, there has been a law that now has actually been thought of breaching data protection, because the police are being given access to the testing database, so that if people have to self-isolate because they've tested positive or they are confirmed contacts of someone who's tested positive, they can be fined if they don't do so. And that is how stringent the UK has to go, because now we are recording something like 17,000, 18,000 cases a day. And if you look at the Office of National Statistics data, it's even higher. The estimate is about 28,000, 29,000. Why am I making this analogy? I'm making this analogy because if you look at it, what you post, Israel, and you look at the Ghana Health Service data, the number of new cases are relatively low. Likewise, the number of active cases are also relatively low. I think they are one of the lowest since this whole pandemic got to Ghana. If you then transpose that to the behaviors you see, in fact, before I came on this, one of the reasons why I delayed was I was watching political party activity and seeing even presidential candidates without face masks, vice presidential running mates without face masks, parliamentary aspirants without face masks. As for the gatherings, forget about it. And I am thinking, yes, COVID this far has been lenient to us by way of mortality and morbidity. But as we go on, I would seek to show that it hasn't been lenient to us from a contagion standpoint, not just in healthcare, but from an economic standpoint. I mean, there's an article that was written by the Minister of Finance in the Financial Times on the 12th of October. And if you look at the data and how our economy is ravaged, I am even surprised that our political parties are making the sort of promises they are making going into the campaign and are allowing people to behave in the manner they are behaving, because if that happens, then our economy is not going to open anytime soon, because our prevalence rates from the serological work that Yao was talking about will continue to be high, but we'll be living in a false flux that the thing has gone away. And that would not help us, because no one would want us to then bring that into their country. So that is how I'm looking at it from that standpoint, that on the surface, it looks like we're okay. From a public health point, it looks like the management has been fine, yes. But the human behavior from a risk management point of view, I think we're getting it wrong.
All right, so as I promised, I'm going to share with you some of the comments that have come through since I posted with some of the things I posted. So the very latest I have here is what was shared by the Ghana Health Service. This is October 14 data. So I posted, the Ghana Health Service reports that on October 14, 33 more people had COVID-19 in Ghana, taking the case count to 47,232 confirmed since March and 310 deaths. This morning, we're going to ask how these 33 people caught the virus and what their situation is. And then I'd also ask the scientists on the panel if we can stop wearing a mask, since many of you have already stopped wearing the mask anyway. So we have 33 new cases, active cases 344, 47,232. So I post this, it has 30 comments, 36 shares. Let's go through some of the comments. Yabua Benjamin, he's just typical, like most people. The Ghanaian, he says, the scientists will obviously say no, but the majority of Ghanaians, whom I presume belong to the Magufulian school of thought, say the era of masking up is over, born exclusively out of observation. Michael Arthur says there's no COVID-19 in Ghana, it's malaria. Orlando says, thanks, Israel. One day I know people will search your name and acknowledge that you have always reminded us of COVID-19. Ohene says, I wonder why many people had stopped wearing the mask as if we are in our normal times. But the last time our president addressed the nation, he said we should continue wearing the mask. So now, why this disobedience? And indeed, this evening, we're expecting the president to address the nation again on COVID-19. Manuel says, so when the scientist tells you we can stop wearing them, will you order us to stop? I don't think that question will be relevant to ask. And then Martin says, we can't stop wearing masks because this virus is very dangerous. Anything can happen. So here's what I'm talking about. This is exactly the way people are feeling right now. Thankfully, we've been joined by Dr. Franklin Esiedu-Bekwene, who's now the acting Director of Public Health. Thank you very much, Dr. Esiedu-Bekwene, for joining us. And I say congratulations is in order on your promotion. I believe I can call it a promotion, Dr. Franklin Esiedu-Bekwene. You'd have to unmute first.
Thank you very much. I think that I struggled to join in because the earlier address,
the link
wasn't working.
Sorry about that.
Yes, so sorry for joining you late. So I don't know what you have covered, but
so we've just been talking about how people are going about business and actually thinking that there's no COVID-19, and some people are saying it's a hoax, others are saying it's malaria. But I know from where you sit, it's definitely not what people are thinking. So we've just been talking about that and why there seems to be that perception.
Okay, thank you very much. So let me say that I try to look at some data before this meeting, and what I'm going to talk about is I try to look at the number of tests done, the number positive giving us. So in that case, I'm going to talk about weekly positivity.
Okay.
So if you look at the weekly positivity, because what we have on our dashboard is a cumulative positivity,
all right,
which is different. So if you look at the data that we have, I try to look at from July. So for July, as at week 29, we had a positivity of 20.1. So that appears to be our highest since July. And then it dropped to, so as at week 42, we are 6.4. So that's the weekly positivity. Then let me look at the monthly positivity. If you look at the monthly positivity, you see for this response, initially, I think we started purely as picking cases based on the case definition. And then with time, in trying to understand the extent of spread, we introduced what they call the enhanced contact tracing, whereby you are doing like more of community spread. So we are trying to dilute because very, very few people have it and you're looking for it. So if you look at the positivity per month, in March, it was 1.03. Then in April, it came to 1.99. Then in May, it came to 5.85. Then in June, it came to 12.31. Then in July, it came to 20.05. Then it started coming down. So August came to 14.8. Then September, 8.47. And then for October, is 5.5. So clearly, if you look at it, it's like it went up and it's down. And I think there's a challenge with the average Ghanaian. Because if you look at where we started from the 12th of March, we started from 2 cases and went as high up where we recording close to about 1,000 cases a day. And now when they are seeing like 30 and 40, they are confused. Is the disease there? And I think that is the biggest challenge we are having now. So now we even have high profile weddings and nobody's wearing masks. And what made me sad was somebody was even shaking. I thought shaking has been illegal. So it tells us that
I actually saw a video where someone was coughing without a mask.
So
at a wedding.
So I think that that is going to be the big challenge now for us, because how do you now get the average Ghanaian to understand that COVID is not gone, so that he now has to now conform to the safety protocols? I think that that's going to be the challenge, and we want to side with the media, people like you, and then to the average Ghanaian to understand that we are not out of the woods yet. The figure or the data is quite impressive. We have gone up and we are down, but to me, and as the health sector, and our DG keeps on saying, we are not out of the woods yet. So the thinking is, how do you get the average Ghanaian to understand that we are not out of the woods yet? And that is the challenge for us now. So let me say that we try to do some, we were doing a kind of a weekly survey on the use of face mask. I think about 2 months ago, it was like around 40%. The last one that we did, it had dropped to be 10%. But I mean, I think that was even generous, because there are instances that maybe we get even 5%. Clearly, the average Ghanaian has stopped to the extent that now, when they see you wearing it, they think that you are ill. And I think that it is a big challenge for us. So I think we need to have a big campaign about getting the Ghanaian mindset that they are not out of the woods yet. So that's my initial comments. Thank you very much.
All right. So I have a few questions for you, and I'm sure the rest of the panelists would also have some questions for you. What I want to find out is, we have, 33 new cases. That's by the very latest that you shared. That's on October 14 on your dashboard. These 33 new cases, I engaged in a conversation, you indicated that these days, because you have fewer cases, you're doing a lot more analytical work on the cases. So if you could share with us, who are these people? Where are they? How are they contracting or picking up the virus, and in what situation are they?
Yeah, so you see now we have introduced what they call the walk-in. So there are people who, hello?
Yeah, we can hear you.
Yes, so there are people who, when they want to travel, some airlines insist that you need to do a test. So they go to, most of the labs in Ghana are accredited. So they go to these labs to do the test. And some of them may be positive. Most of them are asymptomatic. Then there are a few people who are actually having the symptoms, and they go to the hospitals, and then they are found positive. In the time past, we didn't used to have this walk-in, whereby you can just walk into a lab and decide you want to do a test. So that's a new scenario that has come. So a number of these cases are walk-ins who wanted to travel outside. Like when you want to use Emirates, Emirates insists that you do a test. In that case, they are found positive. But quite a number of them are people who were symptomatic and went to the hospital, and a few of them were actually contacts of confirmed cases.
So in effect, you're not aggressively out there looking for anything.
When you say aggressively, I don't get it. Let me say that, you see, if you look at our testing strategy, I want to say that we have moved in phases. Initially, it was purely based on case definitions. Then now we decided that let's sweep the country. So we were going around, you look for a locality where somebody has tested positive, do a kind of community screening. That essence was to find the extent of spread of the infection. Now let's prioritize. And our prioritization was based on certain categories. So one, we were testing cases with symptoms. Then two, we were testing contacts of confirmed cases. Then we were testing at-risk groups, particularly exposed students and exposed health workers. And then now we are doing this walk-in. So these are the broad areas that we are testing for now.
All right, so the 33, for instance, the question I was trying to, the question I asked, and which I'm hoping you can answer is, the 33, are you saying these people just walk in to a health facility to do a test because they had to travel, and that's how come they were found to have COVID? And if indeed that's the case, then that's quite worrying. It means there are lots of people who are walking about who, if they are not going to travel, wouldn't have to do a test, and yet they would have the virus.
Hello. Yes, sir. Welcome.
So he has a call. With once his call, then, but it's a question I'm sure for all of you. You're having the fact that we're having people walking into testing centers because they have to travel. And indeed, how many people are going to travel? So if that's actually the case, then it's quite worrying that there are lots of people who are going about who have the virus, and yet because they are not, they don't need to travel, and so they don't need to go for a test, they're going about with the virus. So I'll start with you, Dr. Bediako.
I mean, I think what is becoming clearer to me right now is the situation in Ghana is, to be perfectly honest, we've practically stopped testing. What we are doing right now, if you think the total number of tests reported by the Ghana Health Service include people at Kotoka International Airport who have landed. They include people at Noguchi and the other places who want to travel, who are getting tested. And then they include a small number of people who are being sampled at health facilities, maybe with symptoms. So what I think what we all need to realize and either accept or rail against, whichever way you want to go, is that in Ghana, to be perfectly honest, compared to earlier in the pandemic when there was an aggressive stance on testing, we are no longer testing. And I think we should admit that to ourselves. The tests that are happening now are walk-ins, people who need to travel and who absolutely need to be tested, people who come into the airport and so are given an antigen test. And so the question I actually have is, these numbers are, some of the airport testing is antigen testing, not PCR. So there's always the possibility that there are a few who would be below the detection of an antigen test and so might slip through the cracks. Despite what, I think the Deputy Minister of Health has been saying, antigen testing and PCR testing are not the same. They are two very different tests. And I was very disappointed actually to hear him equate the two. Yes, antigen tests are better than antibody because, well, better in the sense that they detect current infection. But the levels of detection of these two tests are very different. And I think it's something that I went on record saying over and over again, and it seems to have gotten lost in the mix. But what we're doing at the airport is an antigen test. But if the numbers we are reporting, the so-called tests we are reporting, include KIA arrivees or arrivals, and I guess departures, because now you can't really go anywhere without getting a COVID-19 test. If you take those out of the roughly maybe 900 that we are less than 900 that are being reported on a regular basis, then it suggests that actually of people in Ghana who are living in Ghana, who are residents primarily in Ghana, we're testing probably less than a couple hundred a day. And so what you are, and you mentioned this prevalence, the serological work we've done. There is a clear socio-economic component of what we are finding. When we sample people in Medina Market or in Kaneshi Market, people who take trotro, who live in more crowded dwellings, we find significantly higher levels of seroprevalence than when we go to Accra Mall or we go to other malls and sample people in a different socioeconomic, people who own their own cars, for instance, and live in a single family home. So what we are seeing in Ghana is there is a clear difference in prevalence within certain segments of our society. And the current testing strategy, if you can even call it that, to be honest, is not going to capture that. Now, I sympathize with the idea that from a health perspective, the disease does not appear to be as severe. People are not, the number of people requiring specialized care or in our treatment facilities has dwindled. Now, whether that is because people are just having mild symptoms and not bothering. Initially, there's a lot of fear about it. So if I had a small cough, I show up at the hospital because I'm worried that I have COVID. Now, if I have a cough, I deal with it and I just assume that I don't need to go anywhere. A large number of people are recovering. Like Kwame said, 70% of these cases are asymptomatic or mild. So they don't really need much care. I think we need to begin to ask ourselves in our context. Our context is different from Europe and North America, where they have significant mortality. If indeed it is true that we are not missing deaths, because of course, if people die and they don't get tested, they won't be attributed to COVID. So I suspect, I think it would be hard to hide huge numbers of deaths. But I suspect that maybe our death numbers are slight underestimate because there may be some people who died of COVID-related symptoms that were not tested. But if indeed it is true that our mortality rates are much lower than elsewhere, I think we need to ask ourselves the impact of COVID. We need to ask ourselves where the impact of COVID is really hurting us. And I think Kwame alluded to this in his initial comments about the economy. I think we need to start re-messaging our response to COVID. It is not just about saving lives. It appears that for whatever reason right now, the death rates are lower in Africa, even though they appear to be, I think the last release by WHO, Nigeria and a few countries were showing increases in deaths. So it appears that in some countries, the death numbers are going up, even in Africa. And I think Africa actually had the highest increase in death of any region in the world in the last report that was released a week or so ago. So we can't get cocky or overconfident. But even if we say appears that we've dodged the worst of the mortality, COVID is here. I suspect prevalence in Ghana is at least 20%. Now, if it's 20%, that is 6 million Ghanaians have been exposed to COVID. So the number of 47,000 is just because we haven't tested enough people, right? And it's difficult to test, it's expensive. So if you take the seroprevalence, which says maybe 20% of people in Ghana have been exposed to COVID, and this fits with what is seen in Kenya and Ethiopia and other African countries, that means we have a significant burden of COVID. And as Kwame is saying, as the world begins to mop up COVID, we do not want to be the last ones with COVID, because that will tank our economy even more. So perhaps the messaging to people is less of beware, you might die. Yes, if you have underlying conditions and other things, you are still at risk. COVID is a deadly disease. But the effects of COVID for us may be different than in Europe or North America, where the focus is very much on the health risks and the health outcome. In our case, it may be slightly different, where we may have lower mortality, but our economies will be in the gutter. So there is a clear need for us to help people to realize that just because people are not dying of COVID right now doesn't mean COVID is not deadly. And then, of course, finally, I'll add, there is the idea of long COVID, the downstream effects of being exposed. If indeed 20% of Ghanaians have been exposed to COVID, and like I said, I've seen convincing data from work we have done that people have COVID antibodies, which means they have been infected and have recovered. We have no idea what this is going to mean for this generation of Ghanaians in 10 or 20 years. There is evidence that COVID could have lasting effects. So, we have to think in a much more sophisticated manner about COVID and about the effects of COVID on this country. But I think we need to recognize that we are not, the testing, if you add all these people, really, we are not testing people in Ghana. Now we are testing people who are either leaving Ghana or coming into Ghana. The people in Ghana, we are not really testing as much anymore.
All right. Thank you very much, Dr. Bediako. I know, Kwame Saponsi, you want to have a take on that, and Nana Kofi Kwache as well. But now that we have Dr. Franklin Sedubekwe back on the line with us, I want to put it to him. So Dr. Bediako is making some points. He talks about the fact that they've done some work that suggests that we probably have about 20% prevalence. And so, yes, people may not be dying, but we probably will be living with some after effects of COVID that we haven't actually come to terms with yet.
Yes, so I think that we are also trying to do this prevalence survey because we are aware that you see, if you look at our data, 76% of the people are having asymptomatic COVID. So it tells you that there are quite a number of people who are even in the country who may be walking around without knowing that they have the COVID infection. So that's why to us, our vaccine is the use of the face mask. And I think that has been our message all along. So that is the way we intend to progress. But as I said before, I think, sorry for going up because I had to take a very important course. So sorry for that. I have to speak to the deep. And the issue is the 33 I talked about, they are not people who mainly walk in and were tested positive. I said there are 3 categories. There are people who had symptoms. There are also contacts of confirmed cases. And then we also have these people who went to test, particularly if you are using Emirates. The other airlines don't insist on you doing a test. So the 33 people were in this category. So it's not only people who want to do the work. But I think that we are all speaking the same language. The issue is how do you translate the language to the general population? I think that is where the challenge is. Our figures are low, but if you look at the situation globally, for us now there are 2 threats. The threat of the Americans and the Western Europe, of they entering the country, and then the threat of the Ghanaian not wearing the mask. So those are the 2 threats that we are trying to address as a service. So that's why if you look at our setup at the airport, that's why we are insisting on this serial testing, that we want to be sure that people entering the country are actually coming in with a PCR test. We are doing some analysis, and there are some few instances whereby we have seen that not all the tests are being PCR. So now we are going to be very, very stringent that the test coming into the country is actually a PCR test. Because some just report COVID test, and then you are not sure whether it's an antibody test or it's an antigen test. So we are trying to make sure that we have full grasp of the test into the country. That's one. Then we're also making sure that our antigen test is as effective as we want it to be. So that's one. And then we also want to ensure that the average Ghanaian is going to wear the mask. Then in that case, we are trying to address the 2 threats that I talked about. So is the foreigner entering the country, actually from the US and the Europe, and then the average Ghanaian who is not wearing the mask. So those are the 2 threats that we are trying to address as a service.
All right.
Thank you.
You said when you talk about the threats from the US especially, but if we're having at the airport antigen tests, and the antigen test, as you've heard Dr. Yabediako indicate, the antigen test is not as effective as a PCR. So if somebody has a PCR and they're entering the country with a PCR test, a negative PCR test, and they get here and we conduct an antigen test on the person, that is definitely not going to pick up something that a PCR didn't pick up, and which is what Dr. Yabediako is saying. So are we actually looking at a situation where we're going to upgrade the test at the airport, make it a PCR? Is that something we're considering? That way, we can be sure that whoever is coming in, we're able to catch them at the airport.
You see, so let's say that what you are doing serial testing. So first and foremost, we want to be sure that the test being done outside is PCR. I mean, that is what we need to be very certain about. Because in that case, you are very likely that it will sieve some people who are hitherto positive. It will pick them out. Then the other one is the antigen test. The antigen test sensitivity is not as high as the PCR, but it's quite sensitive. But you see, there's a trade-off. If you want to have a system that can pick cases at the airport, then in that case, you cannot put in a PCR. PCR results cannot come in a matter of 15 minutes. So it's a matter of a trade-off here. But let me say that the Ghana's model is a give and take. It's very impressive because it's convenient for the traveler. It's also convenient for us. That's why we are saying that a COVID test is required. So only few guys will enter the country. And then the antigen will pick the few guys who will pass through. It's not foolproof, but then you want to ensure that we don't like other countries. What they do is that you do a PCR and they say go to a hotel for 2 days and come back. So that's a different scenario. If you want to have a PCR as a double test, then you cannot run it as a rapid test. PCRs are not done as antigen as a rapid test. So that's why ours is a bit of, let's say it's not 100%, but it's about 98 because you are likely to get people within 15 minutes if they are positive. You cannot do a PCR and get the results in 15 minutes. So that's the trade-off. Let me say that it's not an elimination process. It's a minimization process. And that's why so far we have gotten about 80 people who hitherto would have slipped through if you didn't have the antigen test.
I'd like to bring in Nana because he's raised his hands for a while now. And when it comes to the test at the airport, I'm sure he has quite a bit to say. So Nana Kofi, you come in, I'm sure you have some really strong points to make about especially the test at the airports, Nana.
Yeah, so I think what Yao pointed out is actually the thing that I have most been concerned about. And I think it's the necessary context for what Dr. Sidi Bakoy is talking about regarding testing. It is quite obvious that if you're looking at in-country tests, those, like Yao said, are only about at the level of about a few hundred a day. That is in no way, it just is not practical that can be the way that we are going to detect real-time cases. Now, yes, like you said too, we are not seeing the same kind of mortality that we're seeing in Europe. But it's important for us to understand that what that represents in the plain science is an ambiguity. We don't know why that's the case. There are theories about the age population structure and all these other things, but nobody knows for sure. And we should not, therefore, with that ambiguity, interpret it to mean that we've managed the situation while COVID is gone, because the testing levels we are doing do not allow us to draw those conclusions. There have been days where, so I'm just pulling this up here. There have been days where when you look at the general positivity rate being reported by Ghana Health Service, you don't disaggregate it. It gives a very kind of like skewed picture of exactly what's going on. On September 22nd, for example, if you were going by the positivity rate reported by Ghana Health Service, you would have said 13.72%, which is high. That was an aberration for a day. But if you take away all the tests that are conducted at Kotoka alone, you end up having a positivity rate from the in-country tests of about 30% on that day. So we know that it's not just a question of that the testing is diluted, but the way we are interpreting the positivity rate also is diluted by consequence, because if we are including into our positivity rate denominator a large number of antigen tests from people who are coming to the country who are supposedly supposed to have tested already, you're obviously going to get a conclusion where your positivity rate is reducing in numerical terms. But in the context, does that mean that you actually have less community spread? And I would say we don't know that to be the case. Now, with the testing protocol itself, I'm actually pretty surprised hearing. I was just caught off guard by hearing that Ghana Health Service might not necessarily know that tests that are pre-departure tests are all. There's already solid testing that's been done before, and so what we are doing here is really mop-up testing. We really do need to solve that problem because, again, even though we don't know this for certain, we began with 2 cases that we said were all imported, and we end up with 47,000 confirmed cases in this country. And like has been said again, 47,000 is a comical underestimate because we haven't tested as aggressive as we could have. We know from like the work that Wackett and co are doing from serological testing that the prevalence is significantly higher than those tests suggest. And if you look at the way we are responding in other ways to those realities, it also does not send the signal that we think we have a continuing problem. If for example, we're saying at the airport that we don't know for sure that PCR tests are coming in, the tests are coming in at PCR. We know for a fact that what we're doing is antigen testing, which has its, it has some vulnerabilities, if we're being honest about sensitivity and specificity. Then we should be thinking about, the question I ask myself is, why have we not required any kind of quarantine from arriving travelers, which would have been a buffer against the risk of antigen testing failing or PCR tests not being done or being reported as PCR tests accidentally. And I look at the general situation around. I mean, I live near Laboni, near Osu, and I can tell you for a fact, Friday night, Saturday night, Sunday night, guys are out, people are partying. The idea that the clubs are not open is just not true. They are open, people are out there having fun. And those are high risk environments for transmission. And you look at the whole situation, and it's not surprising to me that people are, not complying with the protocols, because the risk communication, both in explicit communication, implicit communication, is suggesting to people that the worst is over, when we don't actually know that. In my personal view, it comes across as though we have, we've looked at the mortality numbers and realized that it's not as lethal here, which is a godsend. It's not as lethal here, not because we are doing anything. It's just, we actually don't know why that's the case. Again, we haven't empirically evaluated all that stuff, and has been a blessing in many cases. But you look at that and you realize that line of messaging that has gone out since, I'd say, mid-April, and around the time the lockdown ended, that the worst is over, things are under control, the numbers are coming down, even when empirically they were not. It has given a false sense of security to a lot of people. And my concern right now is the question of treating it as though the only problem with COVID is that you're going to get infected and have respiratory symptoms when you have COVID-19. When in reality, as Yao said, as Kwame has said, there is a risk of long COVID. And we are, in fact, if you look at our strategy, there is absolutely no kind of contextualization for that risk. There's no kind of effort to prevent actively, infections from going on. What we are seeing, yes, it's a strategy that's around identifying people who are symptomatic and testing them. But it's important that we acknowledge what that does to the positivity rate in terms of skewing it, what the airport numbers being included in those numbers also do to skew it, and what that means in terms of community spread, not in terms of the fact that it's out of control and going crazy, but the fact that we don't know what we are saying we know, which is that we don't actually know that the numbers are coming down because our testing has changed in a way that does not allow us to draw those conclusions. So I'm just hoping that in the context of all these things, when it comes to risk communication, the risk communication branch of the Ghana Health Service will really double down their efforts, because if the basic conditions for COVID-19 to spread are virus in circulation, which we have, and a lack of behavioral adaptations like mask wearing, which we are not doing, then it's magical thinking to say that we don't have actual COVID-19 circulation in large numbers. We just have not made the effort to test to know that for sure. But I hope the risk communication department can really up their game, because especially when we know that the airports are open, when the sending countries for most travelers are countries where we are seeing such high and explosive rates of COVID-19. I mean, 2 weeks ago, if you had told the average, 3 weeks ago, if you had said that, Europe would be having debates not about if they should lock down, but what the scale of the lockdown should be, like in the United Kingdom, national lockdowns or localized lockdowns, it would have seemed kind of an exaggeration. But we are seeing that now, because that is what COVID-19 does. It catches you when you're complacent and when you're cocky, and then it takes action there. So I hope that our risk communication can get a lot better, because if you contextualize the testing effort we are doing, it's quite clear that if we are not covering our basic risk communication and possibly thinking about how airport quarantine can help us minimize that risk, the people will get infected, will import more cases, and there's that risk out there.
Okay, I'd like to bring in Kwame Siedu here at this point. So we've heard quite a bit from Dr. Franklin Siedu Bekwe and Nana Kofi Kwachenya Bediako. I'd want you to also put out your thoughts, and we can have Dr. Franklin Siedu Bekwe respond.
Thanks, Israel. Yes, it's interesting, some of the things that Kofi has said. I mean, if you look at the testing strategy that he's just put out and the disaggregation, I was going to do the disaggregation of the data, but Nana Kofi has done it already, so that's fine. But then I'm going to situate other things in context here. I had always known that the prevalence rate in Kenya, for example, was about 21.2%. There's work that's gone on also in Zambia, which comes to a similar figure. Yao has just said that Ghana, based on their serological work, the prevalence is around 20%, which is calculated to be approximately around 6 million people. Now, you've got to situate this in context, because COVID is a disease where the antibodies also wane very quickly, which then means that the 20% they are getting, perhaps for people who had it in February and March, who didn't bother testing, they are not part of the 6 million. So then you've got to do what we call the excess calculation to try and estimate, based on the weaning period, how many, what percentage has been missed from their serological testing. And I've just been doing an off-cap calculation, and that would add on an extra 9%, which would take us to about 29%, because they are saying that the antibodies wean within 6 to 12 weeks. Is that not correct? Yeah, that roughly that's what's weaning. So yeah, whatever you are picking up now is people who got the infection in the past 12 weeks. All those who got it before that are not factored into their prevalence calculation as it stands now. So if you do the average calculation, which is what I've done, you're talking about 29-30% of Ghanaians being exposed to COVID. And this is based on sound data. This is not me churning out numbers. This is work that has actually been done in Ghana. And if you talk about a third of our population, you're talking close to 10 million people who've been exposed to COVID, who are now one way or the other metamorphosizing as, let's say, 50,000 people, because that's what we've tested and we've got. Why am I making all these calculations? I'm making this calculation because if you look at the data coming from Oxford University, the post-COVID syndrome is showing that about 60% of people who get it between the mild to moderate are having the after effect up to 4 or 5 months later. And this is data that's coming. And I'm quite sure it's similar in Ghana, but the people are just not bothering, because post-COVID is also, it is stratificated. There are the people who have the fatigue and the coughs and all that going on for 3 to 4 months. And there are the people who get the primary renal failures of this world. They'll get the clotting problems where their D-dimers start going out of the window and all that, who will be the ones. But more importantly, if the calculation coming out of the UK and Germany saying about 9% is sort of the disease burden long-term of people who are exposed, who are going to be added on to our public health burden, I look at our health expenditure and I'm like, last year, if you look at our GDP, 4.1% of our GDP was invested in health, of which only 37% came from government, 52% came from the private sector, with the remaining 16% coming from development partners. These development partners are being hit and are not likely to be able to overlay us as well as they have done. And that was why in my preliminary assessment, I referred to the article written by Ken Ofori-Atta in the Financial Times. And I said, he's actually arguing that the resource envelope for lending of IMF should be doubled, and plus Africa should be allowed to go into the reserves of the West that they are not using because our economies have been ravaged. And when I read that Financial Times article, I remember speaking to my colleague, Theo Champong, and saying, Theo, it's surprising that with all this going on, the risk communication is so low in Ghana because we don't have the fiscal space to even do anything, because 60% of the government's contribution, about 26%, is actually going for salaries and emoluments. So we don't even have the fiscal space to take on any additional disease burden. Now here is us, looking at a prevalence rate of 20%, or let's say 30% if you do the average calculation, and we're assuming that, let's say 1 million of them would have a long-term disease burden. Are we planning for this? And I make all these estimates because if you look at the UK, that has proverbially hit the fan now. And it's a serious conversation that is being had. And this week, they are going to start mass testing. Why are they doing that? Because when they found out the testing strategy was missing 70% of their, their cases based on all the calculations. And from the work Yao and Co have done, we are having the same numbers as well. You only have to calculate it. They realize that this is not going to stop and the economy is going to hit. So the only way is to, and that's why they talked about a circuit break or restricted, localized lockdowns. Test massively. So if you look, for example, they are introducing what's called the LAMP testing. Yao would be the one who understands these things more. But basically, it is similar to the antigen testing because it amplifies a section of the RNA of the virus and identifies it quickly. And they're going to post it widespread to homes so that people can test and self-isolate just to break the chain. When countries do this and they get it under control, if, like you said earlier, we become the mop-up country for this virus because our testing strategy allows us to only identify a few, but our serological data is giving us something entirely different, what is going to happen is that these governments are not going to come to our government for the data from the Ghana Health Service. They are going to go to the scientific journals and what Yao and Co publish because they are peer-reviewed, and they are going to use it to inform their travel advice for countries like ours. Then,
okay, Kwame, I want to come in here. You talk about the data that it's available at Oxford, or the work that Oxford has done or is coming out of Oxford. But I also ask myself, is it appropriate to look at the work that's been done or research that's been done in the UK, for instance, and use that as a yardstick for us here in Ghana? When, if you just take a look at the fatalities, for instance, and the people who are dying from COVID, we can't compare ourselves to what is happening there. So definitely there's something happening in Ghana that is quite different. Or
I agree.
I keep on saying the kind of virus that is ravaging the West is not the same kind we have here. So would it be fair to say, or appropriate to say, if this is happening here, we should worry about it here in...
Yes, yeah, and that's why I'm looking at the economic consequence. I'm not looking at the health consequence. And I have said on a number of programs when they started that for me, the mortality in itself was an emotional indicator. I've always been worried about the contagion that this causes economically, educationally, and health-wise. And that is why I'm making these analogies. So the analogy I'm making is to say, if our finance minister is writing that we are struggling, we are tanking because of COVID, and our strategy is not going to allow us to open up. We may not be dying from COVID, but we may be dying from economic constraint. That is the point I'm making. And that is why you can make this analogy, because why am I using the analogy? I'm using the data they are getting there, comparing it with what Yao has told us they are getting, which is no different. And what I am saying is that, yes, it's not killing us. And we all agree on that. Yes, it's not making us very unwell, and we all agree on that. Yes, it's not filling our hospitals and running our health system over. We all agree on that. But it is absolutely battering our economy. And we all agree on that as well. And that is where I am saying that if you look at calculations that are coming out, like some work Thierry Champon and Co are doing on Ghana, our economy has gone back about 20 years just because of COVID. And these are the things that scare me. So that is why when I'm talking, I don't just talk about the health consequences or the health numbers. I try and correlate them to the bigger picture.
Okay, if you make the point about the economy suffering, in the last few months, we've lifted the lockdown and people are going about their business. We're gradually opening up the country and the economy. Isn't that what we're supposed to do to ensure that we recover from whatever has been happening to us that hits the economy and tanked the economy?
You see, the point you're making is that you're making a huge assumption that our economy is very highly locally based. Unfortunately, it's not. Our economy is only a third, if so, locally based. And that's why I used our health expenditure per capita as a calculation index, because that's Ghana. Only 37% of our health economy is controlled by our government. The remainder is controlled by the private sector and development partners. This is data from the government of Ghana, and it's readily available. I can share it with you. I've shared it with Joy FM in the last time I was on there. So if you say that, yes, we're opening up, that's true, but we don't generate, that is why our tax collection and all that has gone down. We don't generate the revenue required to drive that economy locally. We generate a lot of it externally, and even foreign direct investments and all that have a big role to play in our economy. And so we shouldn't be looking at this just from the basis. And that is why the risk communication is very important. Because if we let people believe that, oh, we're opening up, and like Nana was saying, the nightclubs are open, you can still have fun. We don't really see. Have you taken a look at how our city is performing against the dollar or the pound in recent times?
Okay. Let me bring in Dr. Abediako.
Yeah, I just wanted to, buttress what Kwame is saying. I mean, I think the virus is the same. I mean, in terms of, Israel, you were saying, a different virus. It's not a different virus. We've sequenced it. I've seen it with my own eyes. This virus actually doesn't mutate very much. And the virus we have in Ghana is over 97, 98% similar to even the Wuhan strain that was in China. So there are a few unique mutations in Ghana that we can take advantage of to track its movement within the country. But in general, the virus...
You see the issue I raise about the virus is that here is a Ghana where we're not wearing face masks. We're not observing the protocols. And people are going about their business. They're having fun. They're coughing at weddings without wearing masks. And yet we are not dying and people are not...
Yeah, so I think that the thing... I'm getting there. So the virus is the same, which means the virus in Ghana poses the same risk to people in America as the virus in America. So yes, we somehow, and like Nana Kofi said, we don't fully understand. There's a lot of hypotheses out there. It appears probably to be at least partly due to our age structure. Africa is a very young continent. Our average age, I think, in Africa is like 19 years old. So if you look at the people who are really dying in Europe and North America, they're typically older people. Unfortunately, those people are already dead here, to put it bluntly. All right. We don't, our life expectancy in Ghana is, I think it's barely 60, if it's there.
It's 64.1.
64.5, yes. Versus I think in Japan, it's like 80 something, right?
83.
So, there you go. So we have a younger population. Other African countries are even worse life expectancy than Ghana. So in general, Africa is a younger continent. It may explain why we have not had as much mortality. Also, we have exposure to a lot of other infections, malaria, other things going on. Our immune responses, our immune systems, I'm an immunologist. COVID kills you by an overactive inflammatory response. Malaria does the same thing. So there is some, we've not yet been able to prove it yet, but I believe that will come in the coming years. There is some suggestion that exposure to diseases like malaria has tolerized our immune system to a certain point that we don't overreact as much. People are still dying, but those people typically have underlying conditions. Whatever the reason, whether it's age, malaria, or the other things, yes, it is true. I think we all agree that we don't see bodies in the streets the way it was predicted. And thank God for that. Because if COVID had come here with the mortality rate that is in America, I guarantee you that half of, it would have been completely devastating because we just do not have the infrastructure to handle it. But like Kwame is saying, the virus is here. So it's not killing us, but it is with us. And right now, America doesn't have much in a quarantine. You just enter because they have so much COVID. What the heck? You might as well just come in. But the moment they figure it out, and they will, the moment the UK gets a handle on it, we will start to see travel restrictions. It won't just be you have to quarantine. It will be you cannot travel here because they will not risk it exploding again. And so we have to be, in fact, we need to mop it up and we need to be COVID-free before they figure it out. Because if we don't, they will just block us. Already we are not, we depend more on I mean, I'm not an economist, but I think Kwame has said it very, very well. Our economy depends on resources coming in. They can do without us. We cannot do without them. Look at the travel advisories that happen normally for terrorism and for other things. When have you seen Ghana ban Americans from entering, even though there's more gun crime in America? But Kenya and other countries are constantly being put on restricted lists because of Al-Shabaab or Boko Haram in Nigeria. The structure is such that African countries are much more vulnerable to these travel advisories and these blocks. Either they'll prevent their people from coming here, which will hurt us economically, or they'll prevent us from going there. So we really need to get our messaging right that yes, by God's grace, by all these different measures, COVID-19 is not as fatal health-wise, at least for now. We don't know about long COVID, but at least for now, it does not appear to be wiping us out the way a few people may have predicted. However, if we don't get a handle, and we are not getting a handle, it's true. The president has said nightclubs, every address he said, nightclubs remain closed, but I go around and nightclubs are open. So it's like people are blatantly flaunting the president's own words. How much more mask wearing, how much more handshaking? We have, I think it's because our messaging was COVID is a deadly disease, it will kill you. And now it's not killing people. People are like, I'm fine. But we need to explain to people that Ghana and indeed Africa cannot, as I said before, be the last place that COVID is alive. Because once that happens, then we will be isolated. And that will be more devastating to our economy than anything we have so far seen. And so, but at the same time, COVID is a health problem. You don't economically solve COVID. You solve COVID as a health problem through activities like Dr. Esiedu Bekwe and others. So it's a health problem. It's weird. The consequences are financial, but the ways that we prevent it are rooted in public health strategy. And that's why it's a little bit complicated because we are used to Ebola, it will kill you. Therefore, take care of your health. In this case, COVID may not kill you, but it will kill your pocket and you may die of starvation or whatever. So I think we have to begin to be much more, like I said, sophisticated in how we view the effects of COVID. But at the end of the day, the way we prevent it is still back to the good old social distancing, mask wearing, hand washing, and general discipline that has been preached from the beginning, warning us about its health consequences.
All right, so you make a point, and I appreciate the point you're making, that yes, COVID may not kill you, but it would it could kill your pocket. If we had a population which we told that, look, COVID can kill you, and these people still were not scared, how do we sell the economic argument to them and tell them that it's going to kill your pocket? Because they can't really appreciate that when you tell them that COVID is going to hurt your pocket in the long term. They're not going to, I don't think they're going to get that. We'll come to that. I want us to come to that. I just wanted us to set the premise. And I want to come to Dr. Franklin Esiedu Bekwe. You heard all that that's been said. And for me, the question I want to put to you is, are you able to tell, or has the Ghana Health Service done any work that shows why we're probably not having, or COVID is not impacting us as badly as it has other countries?
Thank you, Israel. I think that I will be going off soon because the president is speaking today. I need to do a few things for him. So let me say that for now, I think we need to appreciate that some actions took place in the past which were very timely. And those actions have been quite useful to the population. If you look at the instance when we introduced the mandatory lockdown, the mandatory quarantine, I'm sure if you look at that time, there were 1,000 Ghanaians or 1,000 travelers that were entering the country. And then over 10% of them were actually positive. Those 10% would have had multiple effects. So I'm sure we'll not be talking about 47,000 now. Probably we're talking about multiples of 3. So those initial interventions were very, very important. Let me also say that for our response, you see, certain initiatives were taken that even other countries were not sure the use of it. Like this food lab testing, that technique, very, very useful. So we took certain decisions at the early stages, and that curtailed our numbers. You see, after some level, you get explosions. So those things somehow has helped us to minimize the numbers. But now that's also brought a challenge. So now the average Ghanaian is now confused that all over the world, there's an explosion of COVID, and yet we are not having it. I think that you are trying to talk about the population, the age of the population. Clearly, if you look at our data, we have very few people under 18 actually being infected or dying. And then those who are dying are actually up 60 years and above. And as you have said, we don't normally have a lot of Ghanaians who are above 80 years. So clearly the mortality will reduce as you grow in Ghana. But we have a challenge, and I think it has been said across by all. It's about the risk communication. So we are reviewing our strategic plan about how to actually make our communication more effective. And one thing we are trying to do is to engagement of the traditional leaders and opinion leaders. So if you look at what has been done, has been started, now almost all the regional House of Chiefs has been met. The idea is that people think that when the chiefs are demonstrating good behaviors, it can somehow translate into the population abiding. But that's one way. But what I'm saying is that there's a general revision of our strategic plan, particularly to address the challenges of communication. Going forward, I think that if you look at the issue about the disease as it pertains compared to the infection, there's a variance, because in trying to address the problem of disease in the country, we went on to even acquire a lot of facilities that are now actually empty. We went to Ashanti region to acquire Professor Fefo Martin's facility. Now we have only 2 people in. Now we have actually closed down most of our treatment centers. So clearly, it tells you that the challenge of COVID is somehow less now than we anticipated. And that's why we are trying to see how do we get the average Ghanaian to appreciate that maybe we did the right things at the early stage, and that's why we are not getting the effect now. So we are focusing on 2 sides. I said it. Our threat is the people who are entering the country now. How do we ensure that they do not come and add to the infection we have in the country? That's what. And then how do we ensure that the average Ghanaian abides by the treatment protocol? And I think that today the president will talk about it, because the president has been persistent that Ghanaians need to abide by the safety protocol. It's just that it's a bit difficult. But I think that going forward, that is going to be the key message about reconfirming the safety protocols and abiding by it. Thank you.
So I'm going to have my panelists, the scientists who are here, they're going to be giving some advice as to how they think that we can do the communication, go about the communication. a lot better. But you mentioned the traditional leaders, and I'd like to say I've seen something in the last few weeks that I thought is quite, makes me happy as somebody who is a COVID advocate. And the fact that I actually could see the Asantehene wear a mask. I think it sends out a good message. So I'm sharing that on the screen right now to see the Asantehene and other traditional leaders put on a mask. That sends out, I think, some good message to people out there that, look, if even the Asantehene and other traditional leaders are wearing the mask, then you should also put on the mask. But before you go, Dr. Franklin Silveko, I want to ask you, we're aware that the cases that you share with us, as in the mortalities and the rest, is usually quite not as current. So the latest that we have is October 14, I believe. Now, what is the very latest that you can share with us? For instance, the mortalities. We know that we have 310. You have told us that you usually want to vet the numbers before it actually comes out. What's the very latest mortalities we're dealing with?
The very latest will be spoken by the president today. So I think that, but because you cannot be ahead of the president. So I don't think that. But in terms of the active cases, it's just a marginal increase that's occurred. The mortalities hasn't changed much. So I think that what happened was that, you see, when we were doing there's one thing maybe we haven't spoken much. You see, COVID has somehow affected delivery of essential health services. So when let's say we were aggressively fighting COVID, other activities like immunization were suffering. Now, yes, so now we are trying to catch up and make sure that we cover all those areas about reproductive health, immunization. So for the past month or two, we were doing this nationwide campaign on the vaccine-derived polio virus. So, and the same workers who are involved in COVID are the same guys who are also doing these campaigns. So there was a challenge about getting the data real time. So that's why we have had a delay sometimes. Hopefully, now that we have finished campaigns, we'll be able to catch up, and then we won't be that far behind in giving the data. But I think that today, by when the president speaks, we'll put on board the data for the 16th. Thank you very much.
All right, I'd want to give the rest of the panelists an opportunity to ask you some questions before you go, please. So I want to start with you, Kwame. If you have a question for Franklin Siedu-Bekoe, please go ahead.
It's not really a question. I mean, he's put a lot of things. The only thing I would say is about the risk communication. One thing I found strange was that when I read the finance minister's article, I asked myself, based on what he's written to the Financial Times, which is a subscription newspaper, so you even have to subscribe and read, would he be willing to communicate same to the average Ghanaian in Twi or in Ga or in Fanti for them to understand the real impact of COVID on the economy? And how it is that we are virtually going cap in hand saying that we have spent our overdraft and they should double our overdraft, but more importantly, give us other countries' overdraft to spend going into next year. That's one thing, because that's part of risk communication. Like Yao said, if it's damaged, if it's not killing you and it's killing your pocket, you might end up dying of starvation. So if they are telling us from the economic front, oh, everything is hunky-dory, but would be writing in subscription-only journals what the reality is so that the real Ghanaian cannot see it. How are we going to communicate risk? Because the thing is not killing us. We are not being made to understand that it is shortening our pocket and the inflation rate is going up and the pound and dollar are on a race and all that. So perhaps that is one of the challenges the Ministry of Health and Ghana Health Service, like the likes of Kofi, would like to start discussing with our politicians. And this is not even just down to the governing party, but more importantly to them, because the NDC is doing the same. They have people on the economic team in parliament and the committees and all that. They see these numbers. But they are making us all believe that, oh, everything is hunky-dory and we can go around. If they do that, the president can speak, Kofi and Co can put out their risk communication. It would never change anything because of the perception. I've always said that we communicate to hormones, not to humans. And if you pick on the wrong hormones, like I've said repeatedly on this program, the people would be, if you pick on the hormone of love to communicate to me, I wouldn't be scared of anything. But if you balance it on the hormone of reward and the hormone of fright and fear, I'll be very aware that there is an imminent danger. That is where I think we're getting it wrong.
We have a question from Dr. Bediako Kofi, Nana Kofi Kwache.
Okay, mine is just, I think Doc mentioned that they are closing many of, because we don't have so many people requiring isolation, we are closing the treatment centers. So my question is, which are the ones that are currently available, just for people to know where, if somebody suspects they have COVID. Because I know UGMC, for instance, has stopped receiving COVID patients. So where should people go if, you know, if they suspect somebody has COVID-19?
Okay, indeed, that same question is coming from Dr. Godfrey Techi of UGMC, and he says he wants to know which centers in Accra are for case management, and then which centers are available for those outside of Accra. So, Dr. Echidubekwe.
Yes, so thank you very much. I think that in managing COVID, you are looking at the severity of the infection. Is it mild? Is it moderate? Is it critical or severe? So clearly, we're actually managing the very, I would say, critical cases in UGMC and East. And now we have this new facility, that's the Ghana Infectious Disease Center. So the idea is we are yet to finally agree on how to operationalize it. But let me say that the structures that we have in the country hasn't changed. It's just that because the numbers have reduced, that's why certain facilities are actually closing up. So if you have, let's say, if you're a case of COVID, the same facilities in the country are being used. It's just that it's UGMC, which is actually closed up because we are not having that kind of categorized cases that we're using. But if you go to Ashanti region, the Confederation is there, the Kumasi South is there, if you go to Cape Coast Hospital there. So nothing much has changed. It's just that the numbers has made other facilities less active.
All right, I have a few tweets coming through. Josh Abu says, we have kissed it is no longer a pandemic in my country, GH. Kwekwananse says, no, it is not. As in COVID is not a pandemic. We are Africans. We have survived worse. This is just some hyped flu that only got politicians worried. And Mesa Baga Goat, or Etona Mene says, I think in Ghana it's no longer at the pandemic level. Still active cases though. The rate at which people are infected is reducing even when some have stopped observing the safety protocols. Collectively, both the government and citizens have fought a good fight, but it's not over yet. And another one comes, I disagree. How can an infection that was claimed to have that potency be lenient? Why do we seem to fear to admit that they hype the whole pandemic theory out of proportion and that humanity has the ability to survive in ways yet to be discovered? And Etona Menes comes, mass testing is a good idea, but not feasible. The fact that someone is negative today during a mass test doesn't mean they'll remain negative forever. The approach of test, trace, treat, and isolate is better in terms of proper utilization of testing reagents and tracking of cases. And another one comes as they say those of us who continue to wear the mask are too low, which is very true actually. And the people have seen the lights, no more audio restrictions. If they are immune to COVID at their campaign gatherings, why are our parties and nightclubs of any exception? So people, Dr. Franklin said, I mean, you engage the president very often, and you're going to do that now. But the question people are asking is, if we can see the politicians go about their campaigns without observing the protocols, how do you tell the rest of the population that they're supposed to put on their masks?
Yeah, so apparently, I think that's I think that's reason why the president is actually leading the fight to make sure that people actually abide by what we want to preach, so that we practice it. I think that the challenge is the social distancing, but the use of the face mask. I think that the president, for each opportunity that he gets, he preaches it, and I think that this one sure way that we're going to ensure that we all achieve it. You see, wearing the mask, I think it's a bit challenging for almost everybody, but it's the only vaccine that we have. So it's about getting the Ghanaian to do it, and clearly it's going to a leadership direction. And hopefully we'll be able to achieve that.
All right, thank you very much, Dr. Franklin Sedubeko, and it's because you have to leave us, but thank you for making time to join us for this conversation. So I'm coming back to the rest of my panelists here, and Dr. Yabediako, there are people who are saying at this point we shouldn't call this a pandemic.
Oh, I mean, I think they don't understand what a pandemic is. A pandemic doesn't mean that people are dying. A pandemic is a contagious disease that is spreading at a very rapid rate. And as we've said, I think a number of times today, the evidence suggests that the virus is spreading. I mean, if you think about it, if estimates are true that this virus entered with 2 people, which I'm sure was a bit of an underestimate, but it entered via plane sometime in March, or maybe a little bit earlier in February, and has spread. We have 47, almost 48,000 confirmed cases. And as I said, the serological evidence suggests that it is well over 6 million. I think Kwame made a very good point that antibodies wane. So even if I find antibodies in somebody today and I don't find them in somebody else, it doesn't mean that that person has not been exposed. They may have been exposed previously. And there's nothing to suggest that the virus has stopped spreading. The fact that our detection rates or our positivity rates appear to have dipped a little bit is probably more a factor of testing, who we are testing and how we are testing, not so much that the virus is any less prevalent. And I think the only way to really confirm that will be to do what the UK is going to start doing, which is mass testing. Now we have to ask ourselves if we have the resources to do it. I certainly think we have the resources to test more than we've been testing, because we were testing more. And the question should be, now that more and more people are paying for tests because they want to travel, can some of that revenue be put towards testing those who perhaps cannot afford a test? I mean, I think there are imaginative ways that the Ghana Health Service and the Ministry of Health could try to at least do. I mean, this is something I've been talking about from the very beginning, to do targeted mass screenings, to go into especially the rural areas. A lot of our testing has been concentrated in urban areas. If you look at data coming out of Nairobi, suggested that in about July, they think that it peaked around almost 40% prevalence in Nairobi. I wouldn't be surprised. If you look at our own data from the testing we have done, we appear to have a similar peak in July. So it's possible that even in Accra, we are well over the 20%, right? What we don't know, though, is in the interior of the country, what the prevalence is like and what the spread is like. So the pandemic is still here. The pandemic, as you say, the pandemic is real. It hasn't gone away. And I think we need to view it less, for us anyway. In Europe and North America, they are continue to focus on mortality because they do have high levels. People are dying, thousands of people dying a day. But in our context, I think we need to stop viewing, we need to contextualize it, as Nana Kofi said. Every problem looks different depending on where you are. And I think this is where local capacity, once again, is important. We can learn from what they are doing there, but the reason that Kwame can extrapolate the Oxford data to what is in Ghana is because we've done some work in Ghana. If we hadn't done that initial work, you couldn't say anything about prevalence. So I think we need to expand those efforts. And I think, yes, the messaging has to be different. It has to switch from "you will die from COVID" to perhaps more of the economic argument, and more of the realization that this disease spreads. It's a silent spread. A lot of people will have it and they don't know they have it. But yeah, the pandemic is there. I understand why people who perhaps are not as familiar with this field would think that, oh, it's made up. There's a lot of conspiracy theories, not just here, but elsewhere. But I really think we have to have a sober national discussion. It shouldn't just be on shows like this with people who have been beating the same horse from the very beginning. And people probably see my face, they see Kwame. I know Nana Kofi is very active on Twitter. We are the same old voices. People have probably tuned us out by now. But we need, I think the idea that the finance minister could come and make a case and say, look, I'm not a doctor. I don't know about what it does to your body, but I know what it does to the economy. And I think we need to stop minimizing the problem. I think we like to calm fears. Oh, don't get people scared. I think we need to have a seasoned debate as a country from all sectors, critically as analyzing the effects COVID has had so far, but also the effects going forward. Because I think when you talk about the economy, the thing was, oh, the lockdown in Accra was bad. People were living hand to mouth and they were suffering. That is true, but that is sort of microeconomics. The macroeconomics of Ghana are, even though our airport is open, nobody's coming. Okay. We were thinking about, oh, we have over 1,000 people flying into Ghana. At this peak before COVID, you have 3,000 people entering Ghana, I think, in flights every day, the number I've heard. I had a colleague who came back from Japan, I believe, just a couple of days ago. And he told me his flight was practically empty, flying in from Europe. So even though our border is open, no one is coming. And so we are not open because COVID is everywhere. And if COVID is here, then people will still not come. And then it will begin to be difficult for us to also travel as other countries get ahead of COVID, like I've said. So I really think we need a much more sophisticated and nuanced debate and contextually specific debate, not even debate, discussion about the effects of COVID and what we can do possibly to try to solve it.
All right. I think I actually like the bit about the finance minister, coming out there to be part of the conversation, because yes, it will be quite refreshing to actually have the finance minister, for a change, come to talk about the impact of COVID, and that'll be great. Now, I'll go to Facebook. So a number of people have been posting or commenting on the stream, so I'd like to share some of their comments. So Samuel Zan says, "Thank you, Nana. I know." I'm now more composed to listen. Then Dr. Godfrey Tichi says, "Great show, keep it up, Israel." Dr. Bidiakun, I salute. Oh, and we have Karen says, "Israel, we're just not testing enough. Truth be told, it's unfortunate." Kobe says, "Thank you, Dr. Abidiako, for being honest. No testing." Richard says, if it's an antigen test we are using, why is the cost so high? Now that's a question that's been asked several times, and I'm not sure anybody here can answer that. And then Roger says, testing is waste of money. Oh, you think so? Okay. Kobe says, here in Ghana, we're playing with numbers and percentages, whilst the regular Ghanaian needs to walk into a health facility to get tested. Seriously, we're done playing with this virus. They are interested in the money. Kobe says COVID-19 ain't politics. Samuel says, thanks, Israel. This is what we need more and more in this country. That is objective and knowledge-based discourses for informed actions of citizens. This is important for our interfaith efforts through the Faith in Ghana Alliance being coordinated by Caritas Ghana. Social and behavioral change communication remain critical to addressing COVID-19 in Ghana. And it comes back and says, Israel, did you see, for example, the National Chief Imam in Ghana using face masks during open prayers and also alcohol-based hand sanitizers? Great example of religious leaders promoting behavioral change communication. Greg Porter, well, you're all watching. So, I said Doctor. Kwame Sedu. So, what will be your take? How do you feel we should approach this? Dr. Yabediako feels that we should involve more unfamiliar faces. For instance, the finance minister to come and have a conversation with us and tell us about the economic impact of COVID. And yes, the lockdown may have affected each of us personally or directly, but then there's a much greater impact, which is to the general economy, which is suffering as a result of people deciding that they're going to stay away from Ghana.
Yeah, and that's, if you look, that's the line of argument I've taken right from the start of this particular program. And I totally agree that we need other faces. And that's why I'm bringing in other dynamics, like from the educational standpoint, from the economic standpoint, foreign direct investment. I mean, it would be even a good idea to have people who live abroad who used to remit money into Ghana and have been furloughed and all that, and now cannot remit as much, and therefore their families are suffering as a result, come on the program and talk about the impact. So people realize that, yes, you might be sitting in Ghana and say everything is hunky-dory, but that uncle, that nephew, that cousin of yours who always sent you $100 or £100 every month or every other month cannot afford to send you £100 anymore because his workplace is shut down. And he's on benefits, not because the company cannot employ him, but because official directives are saying that. So those are things that we need to get other faces to come in and speak to. The other approach that I think would be important from a risk communication standpoint is naming and shaming. I don't believe for a minute that we should have politicians who speak to us, talk to us, and tell us about all these economic consequences. And for example, I don't care mentioning names. I saw Kisel Atufosin at a rally in his constituency when the former president visited, without a face mask, holding a microphone and happily speaking away. I have seen MPP MPs. I've seen the current education minister, who is a doctor, that whom my own friend do say. I've seen a lot of these presidential aspirants do say. I ask myself, if, like you showed, the Otunfo is putting on a face mask, the chief imam is putting it on, we've got religious leaders, bishops, and all other things putting it on. But the people who we place custody of the country's leadership mentors in are not doing as they say, and we are seeing it live on screen. You only have to open your Facebook, video feed to see them all over the place. What is that telling the average Ghanaian? Then, if we start naming and shaming, the likes of Yao can then be making the correlation, because I know for a fact that they are having cold feet putting out the serological data because it's an election year. I know the game. I'm a political animal and I'm a researcher as well, so I know the constraints we all go through. But I'm a lot more braver than the likes of Yao. So I'll put something out and not care whether people would come and spike me to death or whatever. I don't really care. But Yao wouldn't do that. And so I am quite sure that overage numbers are calculated. He had the numbers, but wouldn't speak to them, because it is dangerous to tell Ghanaians that in actual fact about 9-10 million people would have been exposed, because we will be like, wow. But these are numbers that need to be out, because that is what has informed the UK's change of strategy. And I'll tell you why that has. The UK has the Strategic Advisory Group on Epidemics called SAGE, who advise the Prime Minister. It includes the Chief Medical Officer and the Chief Scientific Officer. When they advised the Prime Minister for a circuit break and he didn't take it, professors from SAGE started going on TV and radio in England and Scotland and telling everybody, this was the advice I gave. This is the research I've done. This is the outcomes. The former Chief Scientific Officer who leads the Oxford Advisory Group was the one who put out the serological data and led to the lung testing. That was the first time I heard that. I didn't even realize that lung testing could be applied in this area. And then I started looking at it and I realized that, yes, now, because of that, they can reduce the testing to $3 to $5. And therefore, they are having a different strategy. But if we have the likes of having cold feet and not telling us these things and getting those of us who would beat the drums to beat the drums, even though we know, then obviously the risk communication is not going to go well as well, because people will be living in a fool's paradise.
Nana, you've had your hand up for a while.
I think with ultimately where we are right now, I do completely agree with the general sentiment that we really do need a moment of pause to act our age, act mature, and really consider what the context is and where we are. I completely agree that when it comes to the risk messaging, we have to go beyond just the question of unyaobe. That's not the situation in Africa for the most part. But we do need to communicate to people that in my mind, right, it's kind of a conceptual challenge where you are trying to communicate to people long-term risk. That's one challenge that we have here, and the nuance around that with long COVID. Then you're also trying to communicate to them about the present economic risk and what that could mean for their long-term economic fortunes. We have to communicate that as well. But even in the way we are communicating, and I think sometimes we have to make sure we are coming back to the science, right? I'll use the mask wearing issue. A lot of the mask wearing advisory that we've been getting, even from the president, has been to the extent to protect yourself. When in the science, that's actually not the modality we're trying to enforce here. We're wearing the mask to protect other people from us if we should be infected. The change of it from I'm taking a personal risk on my own life and what, I'll be damned, to not wearing the mask is something that you're putting other people's lives in danger, that could help. But we've been saying these things again since March, that these are the ways to communicate them, and those things have not been done. And it goes back to, I think, what I was saying earlier about the question of minimization. We have been too quick too often to interpret ambiguity favorably, when we just have to be able to have the intellectual humility to say, this is working in our favor, or we don't know why. We have to be able to have that frankness and candor in the conversation, because if we can't do that, we will overinterpret things favorably. And then when evidence points to the opposite, the political staff and the PR stuff makes it difficult to come back down to the science. So we have to get that right. I mean, honestly, I actually, like when Yao and Co were doing their antibody testing, I went and got tested at Accra Mall. And I frankly thought it was, some of the most important work that's going on right now around COVID-19. It's important that there are people out there doing the research to estimate the prevalence, and for us to understand what that means. And again, to have the character and discipline to understand what that means. Because what we are talking about with if we say there's a 20% prevalence rate, and especially if it is socioeconomically graded, where poor people have worse outcomes, not worse outcomes, but worse, like higher likelihood of being infected, then there's also a moral question there. We ought to actually, be frank, be candid about this thing, because, and again, going back to the long COVID question, the costs long term are going to be meaningful. They are not going, even if of all, like if we're saying there's even say there's a 10% prevalence around the country and 3 million people are infected, the number of them who will have long COVID complications, that is going to be a long-term cost for the country. And we have to actually confront that. Now, my last thing I want to point out is about the airport testing. Again, I felt much the same way Yao did when listening to the Deputy Minister of Health talking about the antigen testing, as though to have explicitly said that the antigen testing is not a rapid test. That for me was uncomfortable. But then to also go ahead and say that PCR testing is a kind of antigen testing, and suggest that what we're doing at the airport is 99% sensitive and all that stuff. Those things do not help. Those things don't help because the average person in the country does not have the kind of background or context to know what is true and what is not. So it behooves those of us who are seen as expert opinions and expert, actors in the field to tell the truth, because we have to tell the truth so people can form realistic conceptualizations of what's going on. So with the airport testing, the reality is that the sensitivities around is in the 80s of the percent, like 84, 85%. That is the reality. And as we test more and more, especially as, if Dr. Atelier was saying is accurate, that we don't even know that some of the tests are coming in, the original tests are being done for departure, are PCR tests, then we need to be having mature, contextualized conversations about what the consequences are, and not pretend like there are no consequences there, or that the antigen testing at the airport is going to be enough. Because as we head into November, when in Europe, in America, flu season begins to complicate their testing efforts, the likelihood that people are even going to be able to go and get PCR tests done is going to be lower for travel. They'll be doing antigen testing, relying on those things. And if we are not, contextualizing that reality, acknowledging it, and then taking steps here, like a quarantine measure. We're not saying quarantine like, everybody should be housed and quarantined at a hotel, but you should at least have it on your book. You should at least say that this is a requirement, because that is also best practice. We need to really think about this thing big picture, because right now we are approaching it with an exceedingly cavalier attitude. I would totally agree. I think political actors have not been helpful in this campaign season by normalizing, large gatherings and the like. But that's why we have regulators. That's why we have, organizations whose responsibility it is to communicate to them and to the public that what is going on there should not be normalized. That's what risk communication at the Ghana Health Service and Ministry of Health, that's what their job is. So it's concerning for me, because it's quite obvious. I mean, it's plainly obvious. When you're wearing a mask, when you are doing the COVID things, you are seen as being, that kind of thing. You are being excessive. You are being, too know whatever. When in reality, what we are doing here is trying to prevent a scenario where so many people get infected that even if the mortality rates are low, the number is still high. If the percentage of mortality or the risk of mortality is low, the raw number is still high. Because we're talking right now about 310 deaths or so in Ghana. Again, like you said, we know that there is a significant lag. In my own work, monitoring when they were putting out the numbers for mortality, so there are occasions where the mortality delays, reporting delays for as long as 3 months, 2 months. So there's a question as to whether we have a full picture as well. But we need to really have a pause here and acknowledge the fact that this is not make-believe. This is not guesswork. If you don't do A, B will happen. That's the nature of a pandemic. So if we are not wearing masks and we know virus circulation, then we know the virus is spreading. The fact that we're not testing to find it should not give us the false security that all is well. And I hope that whatever we hear tonight and what we're going to hear going forward comes back to acknowledging that fact, because you're beginning to hear some messaging from certain quarters about the people are not wearing masks. People don't believe COVID is still here. Why don't they believe that? Why are they not wearing masks? That's not a question of people getting up and deciding. It's the signals they're getting. So I really hope that going forward, we can really come back to the basics, make sure we are doing compliance. And if we are not seeing the compliance, to not pretend like that doesn't mean anything or that is not a consequence, and to actually make an effort to either deal with the compliance question or plan for the consequences.
All right, thank you very much, Nana Kofi. I see Dr. Yabedi has his hand up, and I'll be coming to him shortly. But I thought it would also be good to celebrate some of the people who are doing some things right, such as Asante Hene, which we talked about, who we talked about a short while ago, and the fact that he keeps on his mask, the National Chief Imam, and some other personalities. And then I must also say that there are some organizations or some events too that have been quite compliant. And I take the National Science and Maths quiz, and we all saw on TV how they went about it, and the schools that won and the schools that were thrown out of the competition at some point. This is no shade to anybody, unless somebody thinks that is directed at them. But yeah, we saw them actually practice the, to some extent social distancing, but the masks were very visible for most of the people. And when the Odadia boys had to go to Jubilee House, they actually had their mask on and all, which is all good. So Dr. Yabedi and everybody else, if you have anybody you think that we should celebrate for doing a good job, we're going to do that. Dr. Yabedi, you have your hand up.
Yeah, no, I just wanted to, Kwame was saying that we need to be bold. So I agree with that entirely.
Is there something you're not telling us?
No,
it's not that he knows that there is. I mean, we're all
no.
So, you see, there's something about the elephant in the room that you're scared about. It's a research jargon. Sometimes the timing is important as well, and I can totally understand what is going on in their head and the thought processes that they are going through. Because as it stands now, a lot of people are not doing peer review. They are doing it and publishing immediately on metrics and stuff like that. But people like KCC are not doing it from Ghana. You ask yourself, why are they not doing it? Why are they lagging with the data? It's because of the political economy.
Yeah, I mean, I have to stand up for us a little. I agree that, yes, I mean, so the prevalence study is being written up. Part of the reason is we wanted to make sure we did it well, because when you put something out there, obviously is going to come under scrutiny. And it has taken us longer. I will admit it has taken us longer than we wanted. Our sequencing study is under a peer review. We wanted to go straight. We wanted something that was peer review, so we've gone that way. I agree. We could have done a preprint, but in the end, the timing didn't work out for us. But the prevalence stuff will be out very soon, so that everybody can see it. I agree with you that we need to be bolder, but I think the challenge someone like me has, I mean, I have been on Israel show. I've been on, I've become more famous than I'd like, to be honest, thanks to COVID. But I am, I'm relatively new to working in Ghana. Two, I'll consider myself relatively junior. But the issue is we need, if I'm to speak honestly about the scientific discourse in this country, at the higher level, in Ghana, we respect professor and we respect gray hair. And I need my senior, my mentors, my senior people to also say what we all know. And I think sometimes at the very senior levels, that is where it gets highly politicized. So, I'll see people who I respect, who I know what is going on. But obviously, one, we are in a campaign year, we're in an election year, and that makes everything even more charged. But so I agree that we need to be bold. I think the scientific community in Ghana, generally, when asked, has been very forthcoming. When Kofi Boni was asked about the antigen testing, he said it, and he took a lot of flack for it in the media. And I respected him for doing that. And I tried my best to also, come in and support his statements, at least within the science. When you start talking about the cost, hey, that is an economic and a lot, I decide I can't really speak to the science. I know what the antigen test costs elsewhere. And we've all known that, it's $5, $10. So explaining 150, well, they said, staff are going different places. That is I'm not here to wade into that. But I agree that in terms of the severity of the situation, I think, at least for me, and I think a number of us have been very straightforward in saying, look, COVID is out there. We are now collecting data to now support it. We are almost ready to at least put out what we have. And the hope is that there will be more. I'm happy that the Ghana Health Service is now getting around to try to do this. I wish they had started a bit earlier, to be frank. But I agree that we need to be bold. But I guess my challenge is it shouldn't be the small boys like me who are the only ones talking. It should be the directors of institutions. The heads of our institutions should also be doing it. After all, SAGE is very, very senior people in the UK. So these are the professors. You don't have the young research fellows who are still crafting their careers, the ones who are speaking out. I've come on this show and argued with the Director General of the Ghana Health Service about the trotro issue and the fact that they said trotro, there's no transmission in trotro. That is something that we went toe to toe with, and I think we become friends as a result of it. But I agree with Kwame that I think in general, it's not just individuals, but in general, the scientific community in Ghana, indeed in Africa, has to know when to speak up, because we have the capacity here, we have the know-how. I would have loved to hear more from the Ghana Academy of Sciences. I feel they've been surprisingly and rather disappointingly quiet. They should have been organizing webinar after webinar, enforcing these things. And the Academy of Science, actually in Ghana, we have the unique situation where the Ghana Academy of Arts and Sciences is one unit. So they have the economists, they have the anthropologists, and they have the biomedical sciences. So this is maybe, a challenge to them. Where is your voice in this? You are supposedly the cream of the cream when it comes to Ghanaian academic accomplishment. And they are highly influential people. You have ambassadors, you have really senior people on the academy. And perhaps they need to be utilized more in a non-political way to just lay out the situation. I think the problem is we've politicized COVID a little too much. And that is unfortunate. I believe at the beginning, perhaps a non-partisan commission on COVID should have been formed, where you'd bring all the major political parties together to just deal with the issue and say, let's put politics aside and let's try and do what's best for Ghana. So I agree, Kwame, don't worry, our stuff is coming, you will see, and more is coming. But my challenge is to my senior members, the people ahead of me, to also, I think they are the ones who people will listen to. Me, they'll say, oh, I'll buy, then they'll name. After all, Ghana, we do MBA. So I think I agree with you. And I think that there are those of us who are trying, but I think to be fair, I think we also have to acknowledge that there are people in Ghana, seniority is important, and we need some of our senior voices to join in the discourse without being worried about political ramifications.
Yeah.
And then in terms of acknowledging, I think a lot of, we have to acknowledge a lot of people have worked really hard. A lot of healthcare workers have put themselves on the line, working really hard. A lot of scientists, people at Noguchi and other places who have worked tirelessly to try to help with this situation. And I think many of whom don't get seen. We always see the director generals, we see the directors of Noguchi. We don't see the lab technicians, the people who work, 12, 18-hour shifts trying to process samples at the height of the testing frenzy. We don't hear about those people, many of whom did not get their bonuses. Let's be frank, they did not get the bonuses they were promised, at least not in a timely fashion. And so I think if we're going to acknowledge the heroes, the true heroes are not the senior people. The senior people get awards, they get trophies. But I think, and I'm talking about people junior than myself, we need to acknowledge the lab technicians, national service personnel, people just finished degrees. These are the people who are doing the testing. At least I know from the testing because I've been involved. The people carrying the weight are not people with even PhDs, okay? They are not people with even master's degrees. They are first degree holders, sometimes even diploma holders, who are there pipetting sputum and doing that. So I would like to shout out to all those people who I had the privilege to work with. I couldn't hack it, so I had to stop because it was just such a physical toll. I had to do other work. But I want to acknowledge the people that I saw really putting country ahead of anything else, ahead of their personal safety, to really dive in there, and who I feel have not been appropriately acknowledged. To be honest, I've not heard, we hear the president say it and we say we thank them, but I think we need to name names, name and shame, but also name and praise. And I think the little people need to be acknowledged somehow. When this is all done, there needs to be some list of people who, many of whom got COVID as a result, okay? But I think we need to list them, the doctors, the nurses, the orderlies, and then the lab staff. So I just like to put that out there as well.
Yeah. All right. And indeed, the people who you mentioned, some of these people and the bonuses that they were promised and that which is not coming. And I can imagine that now that COVID is not such a big deal anymore, they probably may never even
not come in.
Yeah, they probably never get. Yeah, I just want to find out quickly, Dr. Bediakun, which secondary school do you attend?
Oh, I went to Akosombo International, so we are non-aligned. although Presec, I almost went to Presec, and then I decided maybe.
Okay.
So, but I didn't. National Science and Maths quiz. If we had been involved, I think I always said my year would have taken it, but they said we are private school, so.
Okay. Come here,
Well, yeah, I agree with a lot of the things Yao has said. I mean, he's absolutely right that we need to acknowledge every little person and every little effort that came into this fight, because the fight is going to continue. It's not going to stop, even though we have become very laid back in our approach. And finally, what I would say is that when it comes to the issue of speaking up, if you take a look at the Ghana Health Service COVID website, you realize that as a result of a number of the conversations that were had by some of us and many other people, a lot of things are now being reported, like the positivity, the R value, the things that initially some of us said that we're required to track this pandemic. And I remember Yao say on one of the conversations we had on here that we were not tracking the pandemic because we're not following those parameters. And I was saying, and Nana Kofi was saying it as well. They are now on the Ghana Health Service website, and they shared, and that's why I, for one, have stopped, because that was the data I was putting out. I've stopped putting it out because the data comes out on the Ghana Health Service website for everyone to see. But what is interesting is what Yao said, that at that time, the R values and positivity percentages that were being put out by some of us, that we were getting insulted on Facebook, if you go and compare it to what is on the Ghana Health Service website, there's no difference. It's exactly the same values that have been put on the Ghana Health Service website, for which some of us were lambasted and all that. And I challenge anyone, it's on their website, it's on my Facebook page, it's on Nana Kofi's Twitter handle, you can go and have a look at it. Why am I saying this? So what I'm trying to tell you is that the senior people have to speak. But when you have a country where we are so politically charged, sometimes they also think about their heads and they wouldn't put their head above the parapet. So it's important that some of us who do not care whether our head is cut or chopped off, sometimes stick our head up and say, okay, go on, take a go, whack it off and let's see. Because at the end of the day, you've got posterity to judge you. Like I said, the data we put out there now has now been corroborated, and they have put out data as far back as when I started putting it out. And you can go and check all that data. And that, for me, is how we build our institutions. It is not, yes, there's people out there who are very nasty people, and that's fine, they can do whatever they want to do. But if we want to move the needle forward with this, and with other things, because we will have other pandemics coming, someday we will become, excuse me to use the word, the senior people. Yeah, I would get there. Some of us may or may not get there because we live in other countries. But those under us, when we become too politicized, would also not have the gusto and gumptions to speak up. And that would actually make the debate even more constrained. Because if you look at it, when Professor Akosa spoke up, what happened to him? Yeah. You think that as a former Director General of the Ghanaian Service, speaking up and getting lambasted that way, a former professor, one of the best pathologists on record in the UK for that matter, speaking up and getting whacked, his colleagues are on stage now, and speaking up and getting whacked for that matter, do you think that another colleague of his would speak up even if he disagrees? No. So the likes of you and I will speak up. And finally, yes, Israel, I went to Addis Ababa College. I'm proud of Addis Ababa College. We went there. We did it. We've done it. You can check our track record. We've done it for the past 10 years. And yes, you can call us what you call a paid Juventus of for all we care. At least we get to the final. That is an acknowledgement by cowards that they cannot get to the final, but they will call those who get to the final names. And we cannot be bothered about it. And whatever you people say, all the name calling and all that, we still go into the final, and we didn't get decimated like all of you expected. Actually, we were just unlucky not to win.
Well, congratulations to you. We can't take it. We can take it away from you. You did good, but like I keep on saying, Accra Academy is going to meet the Odadias in 2021, and they're just waiting to just kick out the Odadias, and as they did to the champions in 2020. So yeah, we can leave it at that. And I don't know, your final comments.
Yeah, so with the shout out, I actually mentioned one of the people who I think has like really stood out and put their neck on the line. Dr. Kofi Baini, to be frank. I remember the first ever time I did, I think it was the second or third time I did a radio interview. He was on there as well. And it was right after a lockdown when even then he was pointing out that in the aftermath of lockdown, testing had been reduced. He came out and said that and held his ground. And again, with the airport testing, came out and did the right thing as well. And I've been saying right from the beginning that ultimately, like the way I saw COVID-19 at the beginning, yes, as a public health person, I saw it as a public health crisis. But as a patriot, it's also a test of our national character. Can we actually focus on the things that matter? Can we depoliticize matters of national importance to the point where this culture of silence does not affect things that really matter, things like science, when it has to do with lives and saving and rescuing lives? Can we do that? And I think there have been people who have really stood out and done a great job there. I want to shout out the Ghana Association of Doctors in Residency, GADOR, who again, right from the beginning, had been raising the alarm that we were not prepared and we were not adjusting quick enough to the situation on the ground. I want to congratulate the Ghana Medical Association for speaking up in July, sending out that statement, pointing out the fact that, especially in July, at the height of the numerical pandemic in Ghana, that what we're being told and what they were experiencing was not the same thing. But again, like Yao said, like Kwame said, we need to be at a point in this country where we can have honest conversations when we know things like about real facts, right? Where people are not concerned about how it comes off politically or how it gets perceived. And the reality is that we are not there right now as a country. So the folks who have gotten up and stood up and done those things, I think really deserve the commendation. Very much like I was saying, also the small people behind the scenes doing the testing, sacrificing and doing that work and not having commitment to them being honored, those people also deserve a lot of praise. And, frankly, people like Yao himself and the folks at WACPIP who are doing the things that need doing, not because somebody says, let's do it now, but because they need to be done with the serological testing and the like. So I'm grateful to the scientific community and the actors within it that have really done the work. I'm grateful to people like Dasante Hene, like, my own Brother de Krapimhene, for also trying to insist on compliance in their own small spheres. But I do think also we really do need to have a frank conversation about the actions of other folks that have minimized, that have skewed data, that have misrepresented stuff, and especially at the higher level where their credibility or reputation has aided in skewing numbers or aided in telling a misleading narrative. I think that's something we have to look at, because there will be other pandemics in the future. One of them will be more deadly than this. And when that comes, we cannot be acting the way we did in terms of politicizing facts and reality.
All right. Thank you very much. To all of you, my thank you to you as well, because you devote 2 hours of your Sundays to me so that we can have this conversation. One of the things that COVID-19 has taught me is that we need to have more of these conversations that are scientific and fact-based, rather than having the conversations that has to do with politics or become politicized, because this is how we can send a message across, and this is how we can encourage people like you to be part of the conversation. Because if you're having conversations that are politicized, then the people who worry that if they speak up, they may be victimized, they won't be part of the conversation. So yes, we should be having more of such conversations. So thank you to you all for keeping the faith and being part of this. I wish you a pleasant Sunday, and you enjoy, just enjoy whichever school you went to, and have a good one.